Chronic Lymphocytic Leukemia, or CLL, is a malignant hematological disease caused by acquired mutations in hematopoietic stem cells, leading to uncontrolled proliferation of malignant lymphocytes, 98% B lymphocytes and 2% T lymphocytes. It is the most common leukemia in adults in Western countries. CLL incidence increases with age, with a mean diagnosis age of 70 to 72 years. Initially, it may be asymptomatic and found incidentally in about 50% of cases. If absolute lymphocytosis is found in a patient over 50 without symptoms, CLL should be suspected. And in this video, we will go through symptoms, diagnostics, treatment, prognosis, and stay tuned for the end because we will also go through a clinical case. And over time, non-specific symptoms develop. These include B symptoms, including fatigue, night sweats, fever, decreased appetite, and weight loss. Painless lymphadenopathy, typically small, symmetrical, and non-interconnected, but can be massive. Infections may also appear due to neutropenia. Hepatosplenomegaly is also a common symptom. And in cases of splenomegaly, it is important to measure its size in centimeters below the ribs at the mid-clavicular line. Dermatological manifestations include leukemia cutis, chronic pruritus, and urticaria. When diagnosing CLL, the key lab findings include leukocytosis with absolute lymphocytosis, which means greater than 4 billion cells per liter of blood. Anemia, which may be autoimmune hemolytic anemia, as well as thrombocytopenia and neutropenia, are also key lab findings. In a peripheral blood smear, smudge cells are typical findings. Flow cytometry helps identify CD markers for CLL, and imaging like ultrasound, X-ray, or CT scans assess lymphadenopathy. And genetic testing via FISH detects chromosomal abnormalities. The management of CLL depends on disease progression. In early stage CLL without symptoms, a watch and wait approach is used, with monitoring every 3 months. The monitoring of blood tests, lymph nodes, spleen size, and symptom evaluation is necessary. Vaccination for influenza and pneumococcus are crucial. Treatment is initiated if symptoms appear, or in case of late-stage disease. The options include chemotherapy agents combined with glucocorticoids, targeted therapy such as ibrutinib, methylprednisolone, or dexamethasone. Monoclonal antibodies may also be used. Supportive care includes red blood cell transfusions for anemia, platelet transfusions for thrombocytopenia, G-CSF with antibiotics for neutropenia, and in case of hemolytic anemia, it may be needed glucocorticoids and splenectomy. The prognosis varies based on disease stage and therapy. Early stage CLL has a survival of 13 to 20 years, and poor prognostic factors include advanced age, high LDH, and low albumin levels. Now let's take a look at a case. A 65-year-old Caucasian man presents with months of fatigue and notices his skin appears yellow. On physical exam, he has tender lymphadenopathy. Blood tests reveal leukocytosis with 95% lymphocytes and anemia with hemoglobin level of 7 grams per deciliter. A peripheral smear shows spherocytes and lymphocytosis. His direct Coombs test is positive for anti-IgG, indicating autoimmune hemolytic anemia. In conclusion, CLL is a common leukemia in older adults. While it can remain asymptomatic for years, progression requires careful monitoring and timely treatment. Early detection, supportive care, and targeted therapies significantly improve outcomes. If you found this video helpful, like, subscribe, and share for more medical content. See you next time.